you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSELA, and I'm honored to welcome you to this week's webinar on the topic of CAR T-cell therapy and cancer treatment. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs like this one. And if you would like to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar, but we invite you to enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Our speaker will be answering questions at the end of the presentation. We may not be able to get to all of your questions today, but we invite you to email us at info@cancersupportla.org if you have any questions that weren't answered today, or if any come up along the way, and we'll make sure that Dr. Oliai receives those questions. And so I will go ahead and introduce him. Dr. Caspian Oliai is a medical oncologist and hematologist who practices in Westwood and downtown Los Angeles. He's a medical director of the UCLA Bone Marrow Transplantation Stem Cell Processing Center, and he specializes in hematologic malignancies with expertise in acute leukemia, lymphoma, allogeneic stem cell transplantation, autologous stem cell transplantation, CAR T-cell therapy, and benign hematologic conditions. Dr. Oliai is triple boarded in medical oncology, hematology, and internal medicine. He completed his internal medicine residency and hematology-oncology fellowship at UCLA and earned a bachelor's degree in biology from the University of Miami, a master's degree in biotechnology from the University of Pennsylvania, and a medical degree from Drexel University College of Medicine in Philadelphia. Dr. Oliai is originally from Philadelphia and enjoys the outdoor lifestyle of California. When he's not working, he enjoys hiking in the Santa Monica Mountains and skiing in Mammoth. And it gives me a great pleasure to introduce Dr. Caspian Oliai. Dr. Oliai, please join us.
All right, thank you so much, Kathy. It's a pleasure to be here. And, my goal is to make sure that everyone listening has a pretty good overview of cellular therapies, specifically CAR T-cell therapy. And I hope the next 45 minutes is productive and helpful. And I hope you learn a little bit. So I'm going to share my screen. All right, so let's get started. So the title of the talk is called Cellular Therapies, and we're going to focus on CAR T-cell therapy. And what the field is attempting to do is move from chemotherapy, traditional treatment for cancers, toward more immune-based therapies. And CAR T-cell therapy is one of these immune-based therapies. So the agenda is to make complex cancers less complex for patients and their families. So hopefully we'll be able to do that. I'll give you an overview of common hematologic malignancies. And the reason why we're really going to focus on hematologic malignancies is because those are the conditions currently that have CAR T-cell therapies available for treatment, as opposed to solid tumors, which are being developed. We'll talk about the prognosis after something called stem cell transplantation, which is very important to understand stem cell transplant in order to also understand CAR T-cell therapy. And then we'll talk about general strategies to improve outcomes, an overview of CAR T-cell therapy, and then CAR T-cell therapy outcomes in specific diseases. And then we'll end off by talking about the future of cellular therapy. So cellular therapy as a whole incorporates stem cell transplantation, CAR T cell therapy, and some other ones that we'll talk about. So here's an overview of cellular therapy. And to understand it, we have to make sure that you understand a little bit about biology and normal hematopoiesis, which means making blood. So you make your blood inside the bone marrow. So think of the bone marrow like soil that's inside the bone throughout the entire body. And there are these hematopoietic stem cells that live inside the soil. Think of them like seeds. And these seeds are what make your blood. And think about these seeds basically making three different types of flowers. Red blood cells that carry oxygen to your tissue. When those are low, you have anemia. White blood cells that fight infection, and platelets that prevent you from bleeding. So all of those are made inside the bone, in the bone marrow, via these stem cells. And this is a little bit more complex, in which we see that we start with the stem cell, and there's different lineages of different subtypes of blood products. And for example, in acute lymphoblastic leukemia, ALL, it's a cancer of the lymphoblast, that type of white blood cell. In acute myelogenous leukemia, AML, it's a cancer of the myeloblast. And for example, in multiple myeloma, it's a cancer of the plasma cell. So there's all hematologic malignancies that are cancers of different parts of the immune system. So I'll start with induction therapy, and I put in a couple photos to make it a little bit personable because it's a really important thing to include patients and families and make everyone understand that we're all in this together and everyone's trying to achieve the same goal. So for patients, for example, who have AML, the standard is to give intensive chemotherapy called 7+3, and that has a remission rate of around 70%. However, these patients typically stay in the hospital for around 4 weeks, and no one likes that. The other option is to give AML with non-intensive therapy. The remission rate's around 65%, which is not chemo-based. And then for B-cell ALL, it's also intensive chemotherapy initially. So this is first-line treatment. And here's a photo of me with one of my patients the day he started and right before he left the hospital around a month later. So once we achieve remission with first-line chemotherapy, the standard would be to take someone to an allogeneic hematopoietic cell transplantation, which is synonymous with a bone marrow transplant and also synonymous with stem cell transplantation. And this is a potentially curative approach in patients who are already in remission. So we don't do this in everyone who has leukemia, but we do this in the majority of patients who have leukemia, because if we don't do the stem cell transplant, these patients will typically relapse. So the whole point of an allo transplant is basically a cure. And in order to achieve that, what we want to do is replace the patient's immune system with a donor's immune system. And when that donor's immune system is in the patient's body, it can identify any residual leukemia cells that have been left over after treatment and eradicate them. In order for the patient's body to accept the new stem cells from a donor, what we first have to do is actually eradicate the stem cells and the immune system of the patient themselves. And we do that with high doses of chemotherapy and sometimes radiation therapy. And then subsequently, we infuse the stem cells from the donor into the patient through their veins, and then stem cells then find their way into the patient's bone marrow and then start growing into red cells, white cells, and platelets. And again, the whole goal is to have those stem cells turn into the immune system, and then that new immune system does something called the graft versus tumor effect, in which this new immune system identifies any residual cancer inside the patient's body and gets rid of it. So let's say, for example, when you start with acute leukemia, you start with 1 trillion leukemia cells in the body. You get intensive chemotherapy. We wipe out, let's say, 99.9% of those cancer cells, but we're still left over with around 1 to 10 billion cells that are cancer cells left over. This stem cell transplantation then eradicates that residual resistant stem cell cancer type in order to cure the patient. So that's kind of what's out there. Important that you know this in order to understand CAR T. And this is currently done for most patients with AML or ALL. And this graft versus tumor effect that's achieved with the allo stem cell transplant is done mostly via T cells and natural killer cells. Here's a T cell in the middle that is from the donor, and what we want it to do is identify leukemia cells and kill them. But what also can happen is it can identify the patient's own immune system as foreign and attack it, and that's called graft versus host disease. And that can cause a lot of trouble for patients. But again, this is from T cells from the donor that are in the patient looking to kill leukemia cells, but at the same time, they can injure the normal tissue. The reason why they are more likely to kill leukemia cells rather than normal tissue is because leukemia cells look very different in comparison to normal tissue. And here's a nice video just showing you a visual representation of a graft versus tumor effect, which will be kind of relevant to understand CAR T in a couple slides.
Inside all of us lurks a serial killer. A killer whose primary function is to kill and then kill again. These are cytotoxic T cells, a specialized member of our white blood cells. They patrol our bodies, identifying and destroying virally infected and cancer cells. And they do so with remarkable precision and efficiency. There are about 5 million T cells in a teaspoon of our blood, engaged in a ferocious and unrelenting battle to keep us healthy. These amorphous blobs move around quite rapidly, pushing out their leading edge and probing their environment as they go. When a cytotoxic T cell finds a cancer cell, membrane protrusions rapidly explore the surface of the cell, checking for the telltale signs of cancer. They kill their targets using poisonous proteins visible here in red. These cytotoxic granules move down special pathways in the cell called microtubules to the interface between the T cell and the cancer cell. The T cell punctures the surface of the cancer cell and delivers its deadly cytotoxins. This is very important in our bodies, where cells are packed together, as it focuses the lethal hit on the target and minimizes collateral damage to the neighboring healthy cells. The fate of the cancer cell is sealed. The T cell then moves on, hungry to find another victim.
All right, great. So hope that was helpful to kind of visualize and put this cellular therapy concept into perspective in which the immune system identifies cancer and kills it.
At the end of this animation, you should be able to
I'm sorry.
explain the role that epigenetics plays in tissue identification.
All right. One second, guys. Okay, sorry. Got to get back to my spot. Okay, so and when the immune system is in the patient's body, it wants to identify these cancer cells, but sometimes it's really hard to do that because it's kind of like Where's Waldo, if anyone remembers these books, in which, you know, Waldo's like the cancer cell, but it's all throughout normal tissue. So sometimes it's really hard to distinguish between the two. And that's when you get graft versus host disease as opposed to a graft versus tumor effect. So now let's talk a little bit about the prognosis of acute leukemia with curative allotransplant, just to put things into perspective to see where we need CAR T-cell therapy to help us. So if you look here, and don't get intimidated by the graphs, these are things that are very helpful for us to see long-term outcomes. On this axis here, on the y-axis, we see the percent of patients who are alive. And on the x-axis, we see number of years that go by. And in patients who have acute myelogenous leukemia who receive a stem cell transplant, over the 5-year period, around 50% of them will be cured with an allotransplant. And if we compare that to B-cell ALL using an allotransplant, a little bit better, around closer to 60% long-term outcome. So this is great because in these patients, if an allotransplant wasn't done, they most likely would relapse and not do well. But we need to do better. So here are some general strategies to improve outcomes. We can utilize novel immunotherapies to make that 50 to 60% long-term outcome better. We can make curative allotransplant safer. We can also make curative allotransplant available to more patients through having more robust donor systems. But most importantly about this specific talk, we can replace allotransplant with more sophisticated and curative therapies. And that's what we're trying to do as a field. So let's first talk about some novel immunotherapies. And it's important to understand how immunotherapy works and the different components in order to really understand CAR T-cell therapy. So there's the initial classification and category of immunotherapy included antibody therapy. Okay, so what are antibodies? So we start with B cells, which are part of the human immune system, and B cells turn into what are called plasma cells. And plasma cells are part of your immune system that then secrete antibodies. And these antibodies will only bind to one thing in the world. So they only bind to one specific protein. And normally in the human body, there's one antibody for one specific virus. Like for example, when you get a flu vaccine, you're stimulating your own body's immune system to create an antibody against that specific flu strain so that when that is in the body, your own immune system can recognize it, secrete antibodies, and kill the flu. Okay, so what are we trying to do in cancer? Well, in cancer, we design these antibodies not to attach to flu or bacteria proteins, but to attach to cancer proteins, which you can see here. And when they attach to cancer proteins, they typically kill the cancer cell. So that's one category of immunotherapy in cancer. Another category is something called a bispecific T-cell engager, or a BiTE. And these are antibodies that on one end bind to one thing and on another end bind to another thing. So on one end, we want these bispecific T-cell engagers, these BiTEs, to bind to the cancer cell. And on the other end, we want it to actually bind to a normal, healthy T cell so that it brings the T cell into direct contact with the cancer cell. And when that T cell is in direct contact with the cancer cell, it says, oh, this looks like cancer, I'm going to kill it. And that's what happens. There's a product called glofitamab that's FDA approved to treat diffuse large B-cell lymphoma. And this is a bispecific T-cell engager, a very sophisticated immunotherapy. There's another bispecific T-cell engager that's FDA approved for B-cell ALL called blinatumomab, also known as Blincyto, and same concept. This side of the treatment binds to healthy T cells through this protein called CD3, and this side of the protein binds to a tumor antigen called CD19, and it brings the T cell into direct contact with the leukemia cell, and that allows the T cell to identify the leukemia cell and kill it. In comparison to chemotherapy, in this situation of relapse or refractory B-cell ALL, the remission rate for chemo is 25% in comparison to the remission rate with Blincyto, which is better at 45%. So this immunotherapy is actually better than chemotherapy in this specific scenario. And in patients who have low-level leukemia, it actually is 75% effective in eradicating. Another classification of immunotherapy are called antibody-drug conjugates. So we already talked about what antibodies are. And in this scenario, this antibody binds to a protein called CD22 on the surface of leukemia cells. And when the antibody binds to it, it has attached to it a toxin. And this is a direct kind of like heat-seeking missile in which it directly delivers the toxin directly to the actual tumor cell. And when that happens, it kills the tumor cell both by the antibody binding, but also by directly delivering the toxin right to the tumor cell. And the remission rate in this scenario for B-cell ALL that's relapsed or refractory, the previous treatment, 80% remission rate, which is really, really good in comparison to standard chemotherapy, which is only 30%. However, although these immunotherapies, these antibody-drug conjugates, and these bispecific T-cell engagers have excellent remission rates, they still don't give us good long-term outcomes. So both this therapy called blinatumomab and inotuzumab, despite having some remission rates up to 80%, the average amount of time that a patient is alive after receiving these therapies with acute lymphoblastic leukemia is only 8 months. And obviously, we have to do better than that. So how do we do better? Well, CAR T-cell therapy is one of the potential areas of improvement. And this is about down here, just a visual representation of, how many patients are actually alive at the 2-year mark. And you can see not many with the inotuzumab. If you can compare that to CAR T-cell therapy, which is the top curve here, much, much better. At 40 months, around 80% of patients were alive. I'm sorry, at 40 months, around 80% of patients were alive. And in this graph here, at 2 years, close to 75% of patients are alive. So much better in comparison to these other immunotherapies. CAR T-cell therapy gives us an improvement. So what exactly is CAR T-cell therapy? So back to the human immune system and the different lineages of blood, CAR T-cell therapy utilizes T lymphocytes in order to kill cancer. And basically what happens is we re-engineer the T lymphocytes that normally are supposed to identify proteins on the surface of virally infected cells in the body. And instead of having the T lymphocytes identify virally infected proteins, they're re-engineered to identify proteins on the surface of cancer cells. This is what a normal receptor looks like on a T cell. And here's what a chimeric antigen receptor, a CAR, looks like on T cells that are engineered. Much different. And here is a really nice video to put it into perspective.
Chimeric antigen receptor therapy, or CAR T-cell therapy, is an emerging immunotherapy designed specifically to target a patient's cancer cells. To date, the most successful of these therapies, CD19 CAR therapy, targets B cells in leukemia and lymphoma. A patient begins treatment by undergoing apheresis to extract normal T cells. In the laboratory, a modified virus, either a lentivirus or a retrovirus, transfers targeted genetic information into the T cells where it is incorporated into the genome. Newly synthesized CD19 CAR proteins are then expressed on the T cell surface. The altered T cells are expanded in vitro and delivered to the patient by infusion. In the body, the engineered receptors bind to specific antigens expressed by the target cancer cells, killing them. With hundreds of trials currently being.
Okay, and that's kind of a visual representation of what's happening in CAR T-cell therapy. And here's a really amazing video of what actually happens. This was done at the University of Pennsylvania, in which they actually show you what their CAR T-cell therapies are actually doing. It's a really quick video, but it's really cool. So this is an actual CAR T-cell therapy killing a cancer cell. Really neat. So,
Between oat milk and almond
I'm
milk,
sorry.
should I drink?
All right.
Neither.
The same mistake twice. Sorry about that. Okay. So currently there are multiple CAR T-cell therapy products out there that are FDA approved. One is called Axicell with the common name of Yescarta. That's currently FDA approved for patients with diffuse large B-cell lymphoma. There's another one called Tisacel, which is Kymriah. That's FDA approved for patients who have diffuse large B-cell lymphoma or B-cell acute lymphoblastic lymphoma in patients who are 25 years or younger. And also Lysacel, which is also called Breyanzi, which is also FDA approved for diffuse large B-cell lymphoma. The products are a little different depending on what's called a co-stimulatory domain. So with Yescarta, the co-stimulatory domain is something called CD28. in comparison to these other two products, which is something called 4-1BB. And basically what these co-stimulatory domains do is they're responsible for having these CAR T cells expand once they're in the patient's body. So remember, what happens is the T cells are removed from the patient's body initially through apheresis, and then it takes around 3 weeks for these T cells to become engineered in order to identify cancer cells. And then after they're delivered back, they're infused back to the patient into their veins. And when it goes into the patient's body, they start expanding. And that co-stimulatory domain is responsible for how robust that expansion and proliferation is and how long that lasts. So with the CD28 co-stimulatory domain, that results in a very robust and fast expansion. And usually there's more side effects with that, but it's good to get really a high level of T cells to kill a lot of cancer. In comparison, these 4-1BB products, the co-stimulatory domain, they're more of a gradual expansion of T cells, but they can potentially last longer in the body. Sometimes they can be in the body up to 6 months later, which is really great to have so that they can continue fighting cancer. So that's kind of how you should think about the difference in the products, is that they have different expansions and different longevity. Here is one of the initial articles that came out in the New England Journal of Medicine that showed the success of CAR T cell therapy, axi-cel, also known as Yescarta, in patients with large B-cell lymphoma. If you just simply look at this graph, you can see that on this axis is the percentage of patients who are either still alive and also have not relapsed. And here is just time. With standard of care in patients who have relapsed or refractory large B-cell lymphoma, this is how many patients have not relapsed and are still alive. Obviously not great. And if you compare it to CAR T cell therapy, there's a significant difference that's very clear between the two. This curve is patients who receive Yescarta. This curve is patients who receive basically standard chemotherapy. This is also true for multiple myeloma. Multiple myeloma has had an amazing expansion of available therapies, specifically immunotherapies like CAR T cell therapy and bispecific T cell engagers. And as you can see here, this is an FDA-approved product called cilta-cel, also known as Carvykti, for patients with multiple myeloma who have either relapsed or are not responding to initial therapy. Here's patients who are in that scenario who received the standard treatment, subsequent line of treatment for multiple myeloma. And here are patients who received Carvykti, cilta-cel, CAR T cell therapy, an amazing improvement compared to the standard of care. And this was FDA approved not too long ago. This publication came out in the New England Journal of Medicine in 2023. And as you can see, this is a huge improvement over what has been the standard of care for many, many years in multiple myeloma. So another way that CAR T cell therapy has really changed the paradigm of treatment for patients in multiple different diseases. And here's a visual representation of a therapy called Drexel, also known as Tecartus. This is for patients who have B-cell acute lymphoblastic leukemia. The remission rate here is around 71% to patients who receive this product for relapsed or refractory acute lymphoblastic leukemia. And the 2-year survival is over 60%, which is really encouraging. If you recall, with those other immunotherapies that were not CAR T cell therapy, the average survival was around 8 months after that treatment. So this is much better. So if you break down how patients do after CAR T cell therapy for leukemia, you can see that those who achieve really, really deep remissions and basically have no B cells left over that are detectable are up here on this top curve, and they do very well, even years after the treatment. In comparison, not everyone has a great response to CAR T cell therapy, unfortunately. And these are patients who received CAR T cell therapy, but didn't achieve a deep remission and also still have B cells that are detectable. They don't do as well. And even if they're in remission, these patients probably need a stem cell transplant subsequently. For acute myelogenous leukemia, there are many, many immunotargets out there, but we have a lot of room for improvements, and currently there are not any FDA-approved CAR T cell therapies for AML. But there are a lot of clinical trials for CAR T-cell therapy in AML. There are actually around, as of the end of last year, there were 10 clinical trials out there available for CAR T in AML. And those are all very early phases. Around 57 patients total were treated, and the remission rate overall was around 50%, which is actually an encouraging remission rate considering that these are patients who have highly resistant leukemia. So hopefully we can develop some new CAR T-cell therapies in AML so that they can become available in the next several years. And I want to mention that CAR T-cell therapy is being developed for solid tumors. And there are many clinical trials currently open, but there are no FDA-approved CAR T products for solid tumors yet. Solid tumors including something like lung cancer, prostate cancer, breast cancer, types of tumors like that. But there are many clinical trials that are open evaluating these. The challenge of CAR T-cell therapies for solid tumors is that if you see the CAR T cell right here, it requires to go through the veins and then find the solid tumor. And then what it needs to do is actually penetrate into the actual solid mass in order to kill cancer. And that's really difficult actually to achieve, is that penetration through a barrier that's solid is physically difficult. In comparison to blood cancers, there's no physical barrier that needs to be penetrated by the actual CAR T cell. Therefore, that's why we see really good remission rates. But we're still trying to innovate on CAR T-cell therapies for solid tumors, and hopefully in the near future, we'll also make some really good progress there. And I want to mention something about CAR T-cell therapy, which is another reason why we really need to innovate in the field and improve things, is that even in patients who have really great responses to CAR T-cell therapy, there are definitely side effects that happen. And the main two side effects that we are concerned about are something called CRS, also known as cytokine release syndrome, and also neurotoxicity, which also has this acronym called ICANS. So what CRS is then when you get that really robust expansion of that CAR T-cell therapy, think of it like when you get infected with the flu. Your body aches, you have high fevers, you sometimes have the chills. A lot of those symptoms are because your own T cells are rapidly growing and killing the virus. Similarly, in CAR T-cell therapy, these T cells are rapidly growing. They release all these things called cytokines, and that makes the body feel achy. A lot of patients have high fevers, and in around 20% of patients, the blood pressure can actually drop because of this really robust inflammatory response. And when blood pressure drops, sometimes organs can get injured, like the kidney or the liver, and we don't really like that happening. So there are certain interventions that we can do, like immunosuppressing medications, one called tocilizumab, which we can give that kind of reduces the inflammation, allows patients to cool off a little bit and get through this cytokine release syndrome that typically happens a couple days after the T cells are infused and usually lasts only for about 3 to 4 days. And then that usually happens when the patients are in the hospital so that when they leave, the CRS can't happen again. But this is a major side effect concern that we have, and that's why a lot of patients are in the hospital when they receive the infusion of CAR T-cell therapy. The other side effect, like I was telling you about, is neurotoxicity. And this can be a really concerning thing for patient family members who are actually in the hospital with the patients. When patients get this side effect, it can cause confusion. The patients stop interacting with stimulus around them. And in really rare scenarios, it can cause really bad things like seizures, which we obviously don't like happening. So when we see this neurotoxicity happening, and even if it's mild, kind of jump on it, we give high doses of corticosteroids like dexamethasone. That allows the neurotoxicity to improve so that patients leave the hospital without having this happen again. And neurotoxicity usually happens several days after the CRS initiates, usually around 5 to 7 days after the infusion of T cells. Severe neurotoxicity happens in around 25% of patients. So we still really need to improve on this side effect. And a lot of clinical trials are looking to see in ways in which that can be achieved. So the two major side effects to look out for with CAR T-cell therapy include CRS, which are high fevers, high heart rate, small percentage of patients have their blood pressure drop, and also neurotoxicity, also known as ICANS, in which patients get confused and don't interact well with their surroundings. And usually both of them last for a couple days, but they can be protracted if they're not treated well. Okay, so I showed you some of the outcomes with CAR T-cell therapy, and then we just talked about some of the side effects. Well, how do we actually improve on this? Because obviously we need to cure most of the patients. So the advantages of what we talked about, the autologous CAR T-cell therapy, is that CAR T-cell therapy can give us very fast responses in patients who have highly resistant leukemia and lymphoma. And it's highly effective in specifically in B-cell ALL, but we still don't know if it's really curative for leukemia, and we know it's probably not curative for lymphoma. So how do we improve on this? Well, there's a lot of things we can do. We can basically look to see why these don't work well long-term and why they're not cures. Well, number one, it takes around 3 weeks to engineer the CAR T cells after they're collected from the body. So that can sometimes be a big problem for patients who have really aggressive conditions that are growing. And also think about it. And when we're taking T cells from the patient's own body and engineering them, we're still relying on a patient's immune system. And a lot of times in blood cancers, especially, this immune system is a diseased immune system already. So why would we expect a diseased immune system to truly eradicate cancer at a curative level? It has its limitations. And then we talked about the disadvantages of neurotoxicity and CRS. All right, so how do we improve things? Well, the field is trying to improve things by actually improving the CAR, the chimeric antigen receptor. This is just a visual representation of what the first generation CARs looked like. And as you can see, as we go on to third, fourth, and fifth generation, the complexity of that receptor increases, and as does the potential for really good outcomes increase. So we're trying our best. CAR T-cell therapy has been around for around 5 years so far. A little bit more than 5 years, actually. And as time goes on, we've been actually doing a nice job of innovating. Another type of cellular therapy that can innovate on the concept of CAR T-cell therapy is something called natural killer cell therapy. And if you remember, the CAR T-cell therapy is the T lymphocyte. That's what's engineered. But in natural killer cells, it's another type of immune cell called a natural killer cell that's engineered. And NK cells are not as picky as CAR T cells. Natural killer cells are abbreviated as NK cells. And they can kill leukemia in multiple ways that CAR T cells cannot. NK cells can kill leukemia through something called antibody-dependent cellular cytotoxicity. They can kill through downregulation of something called MHC1, through something called KIR mismatch, and upregulation of something called NKG2D. Not to get too technical, but just to give you an idea, there's at least 4 different ways that natural killer cells can kill cancer, in comparison to just one way in which CAR T-cell therapy can kill cancer. So for natural killer cell therapy, there's some early phase 1 clinical trials that are currently underway that use natural killer cells from a donor in order to actually kill cancer, in comparison to CAR T cells that are taken from the patient's own body. And the advantage over autologous CAR T cells in comparison to natural killer cells from a donor are that it doesn't take 3 weeks to prepare. We can actually get these what's called off the shelf. Also, natural killer cells, like I said, can destroy damaged appearing cells in multiple different ways. And we rely on multiple mechanisms in order to do this. So this is an innovation on CAR T-cell therapy that's currently being developed. There's no FDA-approved products yet, but there are clinical trials out there, and we really are optimistic that this could even move the field even more into the future. This is just another visual representation of a really good clinical trial out there that uses natural killer cells from a donor, expands these natural killer cells outside the patient, and then infuses them into the patient so that there's no large CRS or neurotoxicity. And this was actually funded by the Leukemia and Lymphoma Society, and we're trying to open up some more clinical trials in something like this in leukemia. And specifically, part of my job is to help scientists develop their discoveries in the lab and make them actually work in people. And at my institution at UCLA, we're developing something called iNKT cell therapy, which is kind of like a really important immune cell that's kind of like an NK cell, but also like a T cell. And we've showed really amazing responses in preclinical studies. And now we're raising funds in order to prove that this is effective in patients. And I just really want to say that it's so important for cancer research to be funded in order for us to be able to actually run these clinical trials so that we can develop new therapies for patients. So back to one of my patients and their kind of journey throughout the cancer process, the leukemia process. He was initially, this is him at induction therapy when he was first diagnosed, right before we started treatment. This is him, still bright smile on his face, maybe a little bit less hair, after he finished his induction treatment, and he did great. He achieved remission. But because most patients with AML who achieve remission will relapse, we had to do an allogeneic stem cell transplant in order to cure him. So this is him at the point of his allogeneic stem cell transplant. And this is him 1 year after the stem cell transplant. He's doing great. And we're really optimistic that he can have a nice long-term outcome. But not everyone does great with this sequence, and that's why we need to move the field forward, continue developing CAR T-cell therapies, innovating on CAR T-cell therapies, and developing natural killer cell therapies and other types of cellular therapies so that we actually don't have to do allo stem cell transplant in the future. It's a tall order, it's a big challenge, but we're all up for it. We need to all work together to make this happen. And we need funding from the government agencies and also private donors in order to develop new therapies. So I hope this helped a little bit understanding an overview of cellular therapies, specifically how CAR T-cell therapy ties into all the treatment paradigms. But just to give you some takeaways, the most promising therapies are immune-based therapies, in my opinion. And we want to make chemotherapy a thing of the past. But we have to achieve better results to make that happen. And we're on our way to doing that. Antibody drug conjugate therapies and bispecific T-cell engagers are highly effective at achieving remission. But as I showed you, they're not cures. Allogeneic stem cell transplant is an immune-based therapy that has been around for about 50 years now that does give potentially curative potential, but it's not well tolerated by many patients who are older due to life-threatening complications. And also it's limited by the need to actually already be in remission prior to using it. So there are patients, for example, who never achieve remission, so they're not eligible for allo stem cell transplant. CAR T-cell therapy is a promising immune-based therapy that has changed the paradigm of cancer treatment. So this has allowed us to move away from chemotherapy toward immunotherapy. However, CAR T-cell therapy causes severe side effects in around a quarter of patients who get it. And CAR T-cell therapy currently is probably not a cure, but it will lead to promising, potentially curative therapies in the near future. For example, natural killer cell therapy is an innovation on that CAR T-cell therapy that doesn't require perfect targets, and hopefully we can do this. But again, it's going to require public and private funding for medical research to achieve these goals. About 20 years ago, there was something called the Human Genome Project that led to a lot of curative breakthroughs in oncology, specifically some really great treatments in chronic leukemias. So we've done this before, and we need to make this happen again. And everyone in the field is really optimistic that we can move the field forward. And thank you so much for your time. Hope this was a little helpful for everyone. And I'm happy to answer some questions. Okay, so let's take a look. All right, I'm going to read the questions out loud so that everyone can hear them. And then we'll go from there. Okay, so one of the questions says, I know we're discussing blood and bone marrow cancers, but is there any insight into solid tumors like clinical trials for triple-negative breast cancer at UCLA? Are the side effects the same? This is a fantastic question. So there actually is a CAR T-cell therapy clinical trial for triple-negative breast cancer that targets something called ROR1, ROR1, and that's in clinical trial. It's showing some potential. There's definitely side effects associated with it, but it's currently open at UCLA and other sites throughout the country. And none of these clinical trial therapies actually have names, so I can't tell you what the name is, but it is a CAR T-cell therapy for breast cancer that's out there, in addition to other cancers like lung cancer. There's no FDA-approved products, like I had mentioned, but we're trying our best to develop these so that something can get FDA approved in the future. There is another question that says, okay, 1 second. Okay, there's another specific question about specific treatment. If there's no response, if in someone who gets immunotherapy treatment, if there's no response after many therapies of immunotherapy, not CAR T-cell therapy, but like maybe like the immune-based antibody therapies that we talked about, is there a correlation between not responding well to other immune-based therapies and how effective CAR T-cell therapy would work if someone didn't respond well to immunotherapy originally? This is a really insightful question. The answer is, if the CAR T-cell therapy is going after the same exact target as the immunotherapy, then that gives potential for there to be resistance to the CAR T-cell therapy as well. However, if the target of the CAR T-cell therapy is different from the target of the previous immunotherapy, then the likelihood of responding will be standard in comparison to the general population. But it doesn't mean that even if the targets are the same, it can't work. It just means that it's possibly less likely to work. This hasn't been truly defined in clinical research, but even if the same target's there, I would say it's still a good idea to try to pursue CAR T-cell therapy. Another question is, can the same CAR T-cell therapy be used over and over again in the same patient? Fantastic question also. Currently, we don't do that, but there are some clinical trials that are looking at that, but there's nothing available currently as standard of care to do multiple doses of CAR T-cell therapy. But that's one of the ways we're trying to innovate on it. Give additional infusions if we see that the T-cells are exhausted after 6 months, for example. We're moving on that way. Next question. There's another question about solid tumors and specifically peritoneal mesothelioma. Is that currently available for CAR T-cell therapy as a future option? I don't specifically know about that specific cancer type, if there's a CAR T-cell therapy available for it in clinical trial right now. Obviously, there's nothing FDA approved for it. A lot of these CAR T-cell therapies that are in clinical trials for solid tumors don't restrict it to one specific type of solid tumor. For example, the one that I was just talking about that targets ROR1 is available for patients with breast cancer and lung cancer, for example. So it would be a really interesting question to look at that for specific clinical trials. So if you want to maybe send an email to the organization, I put this on today, and then I can take a look at it and see if there's anything available, for example, at UCLA. But again, a lot of these CAR T-cell therapy clinical trials for solid tumors don't restrict to just one type of solid tumor. They're open for a lot. There was a really good question about how expensive are these CAR T-cell therapies. They're incredibly expensive, and it's a shame that they are. I'll just say that. It's a complicated way that the prices are determined by the pharmaceutical companies and how much they charge. I want to say they're very, very expensive to develop in clinical trials, and there's a lot of investment that goes into them, but they're also very, very expensive. However, with insurance, insurance covers a lot of these costs. So it's pretty common that patients who get CAR T-cell therapy don't end up having a lot of out-of-pocket expenses because the insurance companies cover most of these costs. But if you think about Medicare, for example, that's an insurance company that's paid for by taxpayers. So even if patients aren't having a lot of out-of-pocket expenses, the expense of these therapies is still spread out amongst society. So it would be great to see these therapies a little bit cheaper, but most patients would have out-of-pocket expenses that are a little bit lower. There's a lot of questions popping in and out. Let me see. There's a specific question about myelodysplastic syndrome and specific mutations associated with myelodysplastic syndrome and stem cell transplant. There's currently, we don't have any CAR T-cell therapies currently for myelodysplastic syndrome that are FDA approved. It's only FDA approved in leukemia for acute lymphoblastic leukemia. But there are some really promising clinical trials that include that one. And looks like there is one at the NIH that I think is a great option. And I think that these are really important clinical trials to enroll in, especially for things like MDS. There's another specific question about once the CAR T-cell therapy is given, are patients put on additional chemo treatments while they wait for the CAR T-cell therapy to do its thing? Very good question. So I need to do a better job of explaining this. So the sequence of events is patients, once their CAR T cells are ready. Hold on, let me just read the question one more time. So, okay, so the first step is to remove the T cells from the patient's body. And then they're shipped off to the company for these cells to be engineered. Usually that takes around 3 weeks. And because a lot of patients have aggressive cancers, you really don't want to wait 3 weeks for the CAR T-cell therapies to even be ready. So in that scenario, you can give something called bridging therapy, which is kind of standard either chemotherapy or immunotherapy in that interval between when they're collected in the patient's from the patient to when they're actually infused in the patient. And again, you sometimes have up to a month in between. So standard chemotherapies are sometimes given in that interval just to keep the cancer at bay and on hold so that you give time for the CAR T-cell therapy to be made. Once the CAR T-cell therapies are ready, the patients receive very light chemotherapy in the clinic just to suppress their own immune system a little bit in order to allow room for the CAR T-cells to rapidly expand. After 3 days of light chemotherapy in the clinic, patients are then admitted to the hospital. The CAR T cells are then infused into the vein, and then they expand over the next week. And patients are usually in the hospital for around 1 week to allow for those side effects to come and go, and then they're discharged around a week later. After the CAR T cells are infused, they typically work pretty quickly, so there's no need to give additional therapy after the CAR T cell therapies is actually infused. I think that's probably where the question was going, but I just wanted to make sure everyone understood kind of the sequence of events. And I believe that is the last question.
Yeah, wow, thank you so much. I am so glad to see how engaged everyone was with the presentation and really appreciate you presenting for us today, Dr. Oliai. I know I learned a great deal, and you can see from the number of questions we got, our participants did as well. But we have reached the end of our time together, and I'd like to thank Dr. Oliai for his time and for sharing his expertise with us today. I want to thank our attendees too for engaging with us and for your really important questions. If you have additional questions that weren't answered, and I know there was one individual, Dr. Oliai, that you mentioned should reach out. You can email us at info@cancersupportla.org, and we can pass along any questions to Dr. Oliai. So that email will be in the chat. And then we have one closing slide that we'll share to take us out today. And Abby will share that in just a minute. So again, for any additional questions, you can go to our website, and that is cancersupportla.org. And if you have any specific questions for us or for Dr. Oliai, you can email us at info@cancersupportla.org. And then we have information up about a Moving Beyond Treatment for CAR T Survivors and Caregivers. This is a 4-week educational and support series of workshops that we are hosting for those who are CAR T survivors and caregivers. We had session 1 last week, but we still have 3 sessions to go, and would welcome any survivors and caregivers to attend. And if you would like to join us for those series of workshops, you can scan the QR code on the screen to register, and we would love to see you there. All right, thank you, everyone. Thank you, Dr. Oliai, for a wonderful presentation, and we look forward to seeing everyone at the next educational workshop. Take care. Have a great day.